Welcome to this webinar on the guidelines of the ERC, which came out a couple of weeks ago. My name is Tino Greif. I'm the current Director of Guidelines, and I have the pleasure to share this presentation with Franziska.
Hi, I'm a pediatric cardiologist from Berlin, Germany, and have had the honor of being in the writing group of BLS with Jan.
We have today 4 distinguished speakers. In the order, Mike Smythe, who will present the highlights from basic life support, then Enrico Baldi from Italy about epidemiology. At the end, not at the end, then Sebastian Schnaubelt from Vienna, Austria will follow on the systems guidelines. And the 4th presentation will be Jana Djakov about pediatric life support. And only some housekeeping stuff, Franziska?
Right, before we start with the webinar, you need to know 3 things. The webinar is recorded, for one. Then if you have any questions, you can type them in the Q&A box, which you should find in the Zoom mask. And the 3rd thing is, if you would like to have a letter of attendance for this webinar, you need to write a mail to webinar@erc.edu, right? Or write in the chat, then I can put in there the email again. And now, since we do not have a lot of time, I would like to hand over directly to Mike, who has been the lead in the BLS writing chapter. Mike, the stage is yours.
Good evening, everybody. So my name is Mike Smythe. I am Science Chair for the BLS Science and Education Committee for ERC, and I'm just going to present to you today the highlights from the BLS guideline. There we go. So clearly the guideline wasn't written by me. It was written by a group of us. Here you can see that my co-writers. We were fortunate to have a patient, a cardiac arrest survivor with us. That's the gentleman towards the center in the blue t-shirt with the sunglasses and the nice blue background, Mr. Wolfgang Keck. For those of you who are familiar with guidelines, you'll know that we weren't just dependent upon the writing group. We use the ILCOR Consensus of Science recommendations. But if you're familiar with that, you know it's quite a robust methodology, and it can be quite complex and quite stringent in terms of the way that it presents recommendations. So within the BLS SEC and our guidelines group, we try to make a very conscious effort to make the guidelines seem less formal, to make them more accessible to beyond just healthcare professionals, so that lay people could access them easily and make use of them. You'll be happy to know that the key messages in terms of basic life support haven't changed substantially. So the way we perform CPR now in 2025 is very similar to what we used to perform according to the 2021 guidelines. So we stress the importance of recognizing cardiac arrest, of making that initial call to EMS, and then starting CPR with a combination of chest compressions and ventilations. As soon as we have access to a defibrillator, to apply that defibrillator and to follow the instructions on the defibrillator as soon as it tells you to stop so it can analyze. Some areas where we did make changes, there's an increased emphasis on things to look for in terms of recognizing cardiac arrest. For those of you who are familiar with the Christian Eriksen sort of cardiac arrest on the football field, will know that cardiac arrest in sport is thankfully not that common, but it is a recognized phenomenon. And those patients who collapse, particularly those who are very fit, may not present with sort of traditional agonal breathing. So just recognizing abnormal breathing, particularly in the context of sport, is an additional challenge. So we've stressed that within the new guidelines. Our approach, or rather the fundamental change that we've made with respect to BLS, is the change in the sequence. So preceding these guidelines, the 2021 guidelines, it was about assessing the patient for responsiveness, then checking their breathing status, and then making that call. Within the 2025 guidelines, we've seen a significant change in terms of now we check for response, then we initiate the call at that time before making the assessment for breathing. And the reason for that is because we have evidence to suggest that the vast majority of calls under the old system was still identified in collaboration with the call taker. So bringing that step forward slightly means that we'll recognize or will reduce the time to recognition of cardiac arrest. Equally, for those who are uncertain, the call taker is there to help guide you in terms of making that decision. This is the 3 steps to save a life. This is sort of embedded now within BLS, but we can't take credit for that. That came from our pediatric colleagues, but we think that it's very useful in terms of being able to portray a consistent set of messages that go out amongst social media and those sort of things. So it becomes a very good, I don't want to say marketing tool, but it presents a nice, easy way to present the guidelines. So check, call, and then start CPR and get the AED on as soon as possible. The algorithm, if you look to your left, you can see the flow chart saying check responsiveness, then call for help, open the airway, start CPR, and attach the AED as soon as possible, and then continue continue CPR until EMS arrives. That's very consistent with the last guideline. However, if you look at the boxes to the right, what we now have is a universal algorithm. So it's the first time we've managed to have an algorithm that is consistent across adult and pediatric cardiac arrest, and both in hospital and out of hospital cardiac arrest. So that's a very useful tool in terms of promoting education, messages to get across. We can be consistent across all settings, so we can use a single guideline, rather a single algorithm to frame how we respond to cardiac arrest in each of those settings. Another thing that we've stressed within our guideline is sort of how we manage AEDs. So there's increasing focus on making sure that AEDs are highly visible. The AEDs should be in cabinets that are not locked, so that they're easily accessible. And equally, wherever AEDs are positioned, ideally, we want to make sure that they are registered with the local EMS service, so that they are aware of where AEDs are and can help in terms of trying to retrieve those AEDs if there are more than one responder. We've provided additional information in terms of where defibrillation pads should be placed. So we've provided better images to show people where to put the pads, but equally we've acknowledged that in some circumstances it may be appropriate to place pads anterior posterior as opposed to just in the anterior lateral position. We've also provided additional guidance on what to do with in the circumstances where a patient is wearing a bra. If the bra is in the way, then the bra will need to be moved. However, if the bra doesn't impede placement of the pads, then there's no requirement to actually remove the bra. So that would be the main sort of highlights in terms of the changes that have been made to the resuscitation guidelines for BLS. And I'd be happy to take any questions if people have any. Thanks ever so much.
Thanks, Mike. That's amazing. And you summarized the entire BLS guidelines in 5 minutes. Great job.
Six on mine. Thankfully, the process of CPR hasn't changed substantially, so there's not a huge amount to say has changed.
Could you tell us a little bit, because the major change is now that we call before the check of breathing, which is a little bit disturbing for some people. Could you explain a little bit more why this change happens and what should people do? They are calling and waiting, or what do you think should happen in this time?
Sure, Tina, absolutely no problem. So under the old system, it was a matter of identifying that somebody was unresponsive, then assessing for breathing, and then making the call to the emergency services. But the evidence suggests that under that old system, people were still uncertain, and they were then making the call whilst they were uncertain. And the majority of cases were actually identified in collaboration with a call taker. And that meant that we were essentially delaying the time to recognition. So by bringing that call forward ever so slightly, what we're hoping to do is reduce the time to recognition. Now, it's all about marginal gains, the same as we have in high performance sport. If we remove that time to recognition forward, that maybe just by a handful of seconds, then we start chest compressions that little bit sooner, which we hope will have a positive impact in terms of survival. What we hope that people will do is they will recognize that somebody is unresponsive. they will start that call using their mobile phone on hands-free, and then they straight away proceed to assess. So if they can make the determination that somebody has abnormal breathing before the call is answered, then they should start chest compressions as normal. But if they're uncertain, then at least they've brought that call forward so that the call taker can assist. Now, it is a big change, but there are a number of countries throughout the world that already adopt this approach, and we don't perceive that it's going to make a huge impact in terms of ambulance call volume. And the reason for that is invariably somebody who collapses in public and is unresponsive is probably going to require an ambulance response anyway. It's just the way the calls are going to be classified initially. So hopefully that provides some reassurance for our viewers.
Thank you, Mike. We have gotten some questions now, so I would like to read the first one to you. It says, in the BLS courses, do we continue teaching choking management and recovery position, since it didn't seem clear in the new guidelines to this?
I think the important thing to bear in mind is that we haven't actually sort of forgotten about these elements. They've just been moved to within the first aid sections of the guidelines. So dealing with choking is appropriate in terms of the first aid courses, and certainly the recovery position is also appropriate to those, because you'll have lots of patients who are both choking and need the recovery position who won't be in cardiac arrest. So it would be appropriate in terms of courses keeping those in, but the guidelines in terms of the new courses haven't been formally drafted as yet, and they will follow in due course, taking into account the changes within the guidelines.
Okay, thank you very much. That was important that you clarified this, because there have been two questions about this. And then there's one, I think it's more of a comment. It says it's just typing 112 because you need to go to assess the breathing. It'll be very important for children because you just make head tilt and chin lift will make the child breathing. Okay, so I think this person referred to the importance of the airway management in children, and referred to the order of calling the telephone dispatcher first. And I think there might be a fifth one.
We might answer also questions after the presentation of the four speakers, because I would say, for the sake of time, I would like to introduce now Enrico Baldi from Italy, who was leading with other people the epidemiology guidelines. And this is rather an important part. Please, Enrico, the floor is yours.
Thank you, Tino. And I will try to summarize the key evidence from epidemiology and to be as smart as Mike. And so regarding out-hospital cardiac arrest, the annual incidence of EMS-treated out-hospital cardiac arrest in our continent, in Europe, is about 55 per 100,000 inhabitants. And this came from the EURECA surveys, but not only from these surveys, but also from the ILCOR reports. And so it is an important matter, as all we know. And who are our patients? The main age is 67 years old. The majority are male, and as we know, the majority of cardiac arrest occurs at home. The forced monitor shockable rhythm is in 20% of our patients, and the medical physiology is in more than 90% of our patients. The two key messages is that the bystander CPR, the median one is 58% in Europe, but with great variability, from 13 to 82%. So this is an important message. And also the IDUs before EMS is 70.5 in median, but with great variability. And this is was demonstrated both in the EURECA surveys and the ILCOR surveys, with great variability among different countries in Europe and all around the world. And the survival is low, as we know. 7.5% is the median survival. Some countries has higher survival depending on the system, but we have to improve our survival, because actually it's only 7.5% in Europe. How first responders, we have many demonstrations about the fact that first responder increase bystander CPR, increase AD use, and increase also patient outcome. However, actually, the implementation of first responder in Europe is inhomogeneous. And so in this chart, you can find that the countries where there is at least one system, but the majority of systems are local systems, and so there is room of improvement for implementing first responders. And also for cardiac arrest registries. The registries are fundamental to comprehend epidemiology. Without registry, we cannot write any chapter about epidemiology, and also to improve treatment. However, actually only 9 European countries have an out-of-hospital cardiac arrest registry with full population coverage, with little changes from 2019 to 2025. And so again, there is room for improvement in cardiac arrest registries. About in-hospital cardiac arrest, the annual incidence is between 1.5 to 2.8 per 1,000 hospital admission. But compared to out-of-hospital cardiac arrest, we have very few data, and we have great variability. As you can see, this is the chart summarizing the data we have actually, and the outcome varies from 27% to 62% considering 30-day survival. So great variability, probably because we have very few data, so we have to improve the data. And another important message is that the proposed standard internal telephone number to alert the emergency team, the 2222, for in-out hospital cardiac arrest in Europe, is rarely implemented in our countries. Only 2 countries out of 14 implemented this number. And so we have to improve this implementation because it was proposed by ERC in 2016. And so, regarding this first part, we, as a key message, we promote the establishment of national registries, both for out-of-hospital and in-hospital cardiac arrest, to use this data for system planning, to support also low resource settings and remote areas, and it is very important because we have to improve the outcome also in that areas, and to implement 2222 for in-hospital cardiac arrest and expand in-hospital cardiac arrest research. And moving to long-term survival and return to societal participation, 1/3 of the patients develop depression after cardiac arrest, including severe depression. And the majority of out-of-hospital cardiac arrest survivors experience difficulties in recovering the quality of life, so physical and non-physical limitation. However, up to now, we have a lack of uniformity in the assessment of these limitations. And fortunately, the latest EUSTEN 2024 recommendation included a clear recommendation on how to collect this data for the first time. And we wanted to summarize that on our chapter because we believe that it is very important to collect this type of data to improve the treatment also after the survival. And in our chapter, you can find also the scales suggested by the EUSTEN, so by our guidelines, to measure the health-related quality of life parameters. And also, we stress the importance for multidisciplinary approach for post-arrest patients, because for out-of-hospital cardiac arrest survivors, we need to put together cardiologists, intensivists, psychologists, occupational therapists, and so on. And so we need frameworks, and not only a single specialist. And remember that it is important the rehabilitation, because on 1 out of 3 survivors receive cardiac rehabilitation, and only 1 out of 10 receive brain injury rehabilitation after cardiac arrest. And so we wanted to stress this point in the key messages, because we suggested to enhance post-resuscitation care and also to measure long-term patient outcome for all the out-of-hospital cardiac arrest survivors. And moving to the last point regarding autopsy and genetics, and this is a novelty in the epidemiology chapter because we wanted to focus more in our chapter about this topic. You know that cardiac arrest in young people is not negligible. There is a great amount of patients under 50 years of age that suffer a cardiac arrest. But there is a difference because coronary artery disease is the most common cause in people over 50, while the other are in the younger, the causes are mainly genetically determined. And so the identification of a genetic condition can affect not only the patient, but the family members. And for this reason, the autopsy is recommended by various European and non-European scientific societies, like the European Society of Cardiology. But despite this recommendation and its crucial role, the autopsy is not routinely performed in Europe. And so we have to improve this aspect. And moreover, 1/3 of the sudden cardiac deaths remain unexplained after autopsy. Fortunately, we can do not only the standard autopsy, but also the molecular autopsy, because in up to 25% of out-of-hospital cardiac arrest cases younger than 50 years old, there is a clinically actionable or pathogenic or likely pathogenic variant in a gene potentially related to the cause of the sudden cardiac arrest. And so we can do the molecular autopsy from the patient, from the blood of the patient, to screening the family. And so it is very important to prevent other cardiac arrests in the same family. And this is recommended again from several scientific societies to retain blood from the patient to perform post-mortem genetic analysis. And so again, we wanted to stress this in our key messages. In fact, we recommend to conduct comprehensive autopsies, including molecular autopsies, in all the patients under age of 50 who suffer an out-of-hospital cardiac arrest, and also to use multidisciplinary teams for counseling of the family, to screen the families, and to prevent further sudden death. I try to summarize our chapter, and I thank also the writing group members, because it was a very teamwork and all the guidelines.
Thanks, Enrico. For the audience, I would like that you wait a little bit, because there are a lot of questions about children coming in. And the last speaker will be Jana, specifically addressing pediatric life support. A lot of these questions might be addressed with this presentation. And also for the choking questions, next time in January, there's another webinar where the first aid chapter will be presented, and specifically in these guidelines, we addressed choking. And now my first question for you, Enrico, is, did I understand it correctly that you want that we take blood even from dead people and not only from survivors?
Exactly, from all the patients, possibly from all the patients suffering out-of-hospital cardiac arrest under the age of 50. And there is data we summarized in the guidelines that stress the importance of EMS in collecting bloods, because the blood collected from the EMS is high quality blood, even better than during the autopsy. And also EMS can collect blood from patients who don't survive and who don't receive autopsy. And so EMS play a crucial role in this one. And so I believe, yes, we have to collect blood, or we have to try to improve the collection of blood from all the patients, because the post-mortem autopsy, so the molecular autopsy, can be done in all the patients.
And if you get the results, what happens afterwards? So did they take blood from a person who did not survive a cardiac arrest? And what happens afterwards?
There is a family. In the majority of cases, there is a family. There are other family members. And so if you are able to find a pathogenic or likely pathogenic variant for a gene that can cause the cardiac arrest, you can screen also the families. And we have many cases of families with 2, 3 out-of-hospital cardiac arrest, or cardiac arrest in general, in the same family, without any diagnosis, because when the young uncle died 20 years ago, nothing was done, and again another young boy died again, and so it is unacceptable in 2025. And so we wanted to stress this concept. We have also to prevent further sudden cardiac death in the same family, and autopsy with molecular autopsy is the only way to do so for the patient who don't survive, obviously.
Okay, thanks. Francisca, I guess we need to move on.
Right, and we did not have any questions for you, Enrico, yet. I think they're might be dropping in later, but yes, we would like to move on to Sebastian in Austria, who would guide us into the world of systems saving lives.
All right, thank you very much for the introduction. My name is Sebastian Schnaubert from Vienna in Austria. I'm an emergency physician there, and I led this chapter. And of course, this was a team effort, as everyone else already pointed out. The systems chapter is sometimes regarded as less important by clinicians or not read at all by clinicians, I would suggest. Surely not read as many times as the ALS chapter, for example, but I would urge you to have a look anyway at the systems chapter, because there's some really nice messages there. No matter if you're working in EMS, if you're a dispatch person, if you are a stakeholder in emergency medicine, no matter if it's in the hospital or out of hospital. So there are very nice messages that we kind of refined, and a few new messages as well. And the first one would be this. You see the chain of survival now. This is not a new concept, of course. This has been around for many years. But in the last chapter, we didn't have the chain in anymore because, well, we thought it's not as important anymore. It's not really any use to clinicians. But this time we thought, well, it is a central figure for resuscitation and everything else going around it. And then we refined it, and not only in terms of, well, making it look more nice, but also in terms of the contents. If you look at it closely, now we included early recognition and the call for help and prevention of cardiac arrest. So everything that goes on before we start CPR. Then we summarized early CPR defibrillation in one chain link of the chain of survival, ALS, and post-resus care in another link. So not two links anymore, but one. So this is the kind of professional care that starts at ALS and then goes on. And then a very important last link, or, well, also the connection to the first link again, maybe, the survival and recovery to restore the quality of life. So it's not just about ROSC or just about survival to hospital discharge, and even not only about CPC or classifying people in good, favorable and unfavorable neurological outcomes. It's about the person and the co-survivors. And I hope this works now. No. Can you maybe override it and go to the other? Thank you. And this kind of, well, summarizes everything that you see here. This is all the main messages from the systems chapter. And the first one in the right upper corner, you see is the new or updated chain of survival. And then there are many quite important messages, I would say. And as I've pointed out, these are important for many, many different people working around or in resuscitation. So for example, we tell you now that it's not enough to have a one-size-fits-all concept. Resuscitation systems must be tailored to local contexts. And this goes hand in hand with the low resource topic that has been going on for some time now, resuscitation in low resource settings, which is not only high income or low income, this is low resource settings. It's not just about countries or money. It can also be about remoteness. Maybe a very rich country does have areas or regions that don't have as many resources as, for example, the capital city. And the other way around, a very poor country can also have, for example, a capital city with the highest standards possible. So this is not a one-size-fits-all concept. And all around the world, when we want that resuscitation guidelines are followed, you'd have to also have a look at where they're followed and which resources there are. Then again, community engagement. This is, of course, critical. This goes hand in hand with public events such as the World Restart the Heart Day or World Restart the Heart Week even. We've kind of refined this, well, looked at it again and said, well, this is really important. It's worked well. It's a really good concept, and we should promote this even further. The school-based CPR this is, I think, one of the most important messages here. It's not just a can anymore. It's not just a suggestion anymore. School children must be educated in CPR. It must be mandatory. And even in Europe, we still have countries, Austria included, unfortunately, where it's not a law that school children must be educated in CPR, which is a pity. There's a map included in the guidelines in the chapter where you can see which countries still don't have it as a law, and we really have to have well, more efforts to achieve this. Then maybe I've also mentioned the dispatch centers or dispatch personnel. Dispatchers must be educated more in the recognition of cardiac arrest. We've kind of not forgot, but this was not as important in previous updates of the guidelines. So this is a very important topic if you work there. First responder systems. All systems working in resuscitation should have first responder systems now. This is also not maybe, or if you have the resources, it's nice to have. No, you should really introduce this if you don't have it yet. And there are very nice examples how it can be done. So there's no excuses anymore not to have a first responder system. Social media and artificial intelligence. This is also a thing that's not been included in guidelines in previous updates. We've kind of summarized what's already out there in resuscitation. You should use social media for education. And in terms of artificial intelligence, we don't really know yet what to do with it in resuscitation. I'm sure that's changing very fast and very quickly, but also be cautious about it because it can be faulty, and we should know when to use it and what to use it for exactly. And then the last point, maybe the cardiac arrest centers. There's been a huge discussion going on about cardiac arrest centers, maybe similar to targeted temperature management, hypothermia, etc. Should all people suffering from cardiac arrest go to a cardiac arrest center or be brought to a cardiac arrest center? We now say, based on very limited evidence, I would say, yes, if you have a cardiac arrest center in the proximity, you should bring your patient there because there's just more experience, etc. But then there's a few other points there. So what about PCI? Should all people suffering from cardiac arrest receive PCI? Well, we say no. If there's clear evidence of ACS going on, then yes, but all the other patients should rather receive a full body CT scan, similar to trauma patients. So this is a very, well, diverse, heterogenic chapter, I would say, many different messages. But I think nevertheless important ones if you want your system to work really well, because, for example, ALS or BLS without a system underlying, all of that is not really working, and you need a system saving lives. Thanks.
Thanks, Sebastian, for this. Maybe my first thought was, could you a little bit explain what is meant by the first responders? Because there's sometimes, for some people, it's not very clear if the first responder is the police or the fire department, or are these volunteers working? So could you explain this a little bit broader?
Yeah. So there's, I would say, two kinds of first responders. There are many different subcategories, I would say, and discussion about the well, best terminology is still going on an international level right now. But of course, you have the professional first responders, I would say, like police, fire brigade, etc., which are, well, sent to cardiac arrest events because they're nearby or they're patrolling the city. Mostly they also have AEDs, not in all systems, but mostly. And then there's lay people or people not on duty. Could also be a police officer not on duty. And mostly this is done via apps, via smartphone apps. And people in proximity, again, of a cardiac arrest are sent there by a dispatch center. But the central element here is, again, the dispatch center alerting all these elements that are available.
Franziska?
Right. Thank you so much, Sebastian. We have one comment. I would just hand it over to you since you might want to say something to it. It says it's great that you use social media for education, and it would be very interesting to look for evidence in this context.
Mm-hmm. Well, there's been attempts to create evidence for that. It's been very difficult because if you can, well, of course, you can imagine that searching social media and summarizing data from that is very difficult and not something we're used to in the ILCOR process, for example. There should be done more in this direction, I think, because social media is getting more and more important for younger people and for older people. And it's just a central part in our lives. So there should be more research there and should be more initiatives there, I think.
Thank you.
Okay, so let's move to the last speaker. Diana will present pediatric life support and hopefully answer quite a lot of questions which came in. Diana, please.
Hello, everyone. Welcome also to the last part, which is pediatric life support guidelines. If I should take it to really quick through, there is a massive work done by the whole PLS group. So thank you for those who were involved. And my words for that would be team up, respond quickly, and take care longer. And it is only a little bit insight into our chapter because there is a massive work done on several parts: prevention of cardiac arrest, pediatric basic life support, advanced life support, special circumstances in pediatrics, and then post-resuscitation care and post-discharge care. So please, this is just a quick go through our chapter as a whole. Oh no, okay. I have no financial conflict of interest for this part. These are my just intellectual conflict of interest. I chair Czech Resuscitation Council at the moment. So if you look at our key messages, there are quite a few from each of part that we've made. And of course, we also embedded the new chain of survivor for the pediatric patients, because this is quite similar if you look at the patient, no matter the age. Prevention is crucial for pediatrics, even more so, I would say, than for adults. And if I look at this patient that came to my ICU, I would say that this might be a patient that is on the edge of abyss. And I might take care in a good way to prevent the cardiac arrest. And that is the most safe way how to do this, because it's much easier to prevent cardiac arrest than to treat it. And we know that in pediatric cases, the cardiac arrest has even worse outcomes than in adults. So we always try to prevent if it is possible. And you can find a lot of prevention in quite a few of our key messages. We have some that are like primary prevention. We want to prevent or we want to early recognize that the patient is in critical state. We want to use a BCDE approach to treat any child who appears critically ill or injured. We also stress out the team approach. We also talk about how to prevent somewhat secondary injuries in families of the patients. And we have also some advices for the systems. But we also take care of something like a secondary or tertiary prevention to even if the child goes to cardiac arrest, what to do to get better results possibly. So we look much more into some of the pediatric advanced life support also in special settings. And we've somehow summarized much more the post-discharge care and post-resuscitation care. We have a lot of new images and infographics, so please do look at them in our chapter. This one is for ABCDE approach in children. And one thing that we've included in all of the parts of our chapter is always include family. So I hope that after these guidelines, there will be no hospital and no system that will be sending the families away from their children during the critical events. Teaming up is another part of our guidelines, and we have also some new images for our chapter about how the teamwork could work in case of cardiac arrest. It's very similar to critical events, so you can use that also for critical caring of the patients. As Mike already said, we've been able to do the 3 steps to save a child: check, call, CPR, and AED. And also during the PBLS, it was a very nice cooperation with the BLS to come with a unified PBLS algorithm that I hope will help without losing the specifics for the pediatrics patients. That is mostly about the respiratory care. So always think about the quality of the breathing if you are resuscitating children. Also, pulse, there is not that many new changes. I would say we have new algorithm, but if you look at it, it's not that different from the last one. We are again advising to start pediatric and support early. You might already heard this from the ALS group, so we also take care of that. In pediatrics, we sometimes start even earlier because we have bradycardia with poor perfusion as one of the status that should use pulse already. We also advise to correct reversible causes that are quite common in pediatrics, so you have to think about that from the beginning. And of course, about post-resuscitation care, we start very early, immediately after ROSC. You should already be thinking about post-resuscitation care. About take care longer, I'm very glad that my other previous speakers already talk about the chain of survival. And of course, the last link of chain of survival is exactly the one that we were missing before, because previously our patient was still lying at the end of the chain of survival, somewhere in the pediatric ICU. What we are actually aiming for is, of course, to have a patient with quality of life and somehow restored, and we want good survival and recovery inside the family unit. So what I think is important to take care about good post-resuscitation care, again, we have this new infographics that covers what we think is important inside the hospital, but you can also find there another one for the pre-hospital management and for the parts that you can manage already when you are outside of the hospital. So the post-resuscitation care was not that involved before, and we also included for the first time the prognostication and suggested diagnostic workup for possible prognostication. We do recommend a multimodal approach to prognostication, and there are some suggested things that we should do as a part of our diagnostic workup after cardiac arrest. With this suggested workup, we think that we might be able to collect more data throughout Europe to get more data into registries. We've also included some information about registries, about pediatric cardiac arrest registries in our chapter. And we also talk about which parts of this workup you can use for modalities associated with good outcomes and which one for the poor outcomes prognostications. Of course, as we said before, always it has to be multimodal. You have to think about pre-arrest conditions, intra-arrest situation, and post-arrest care. And Of course, early rehabilitation, gathering long-term outcome and follow-up clinics is something that was not talked before. And I'm glad that it was both in adult and pediatric chapter the same, that we are now giving an overview of what we think should be a coordinated family-centered post-discharge care. And of course, to also have support groups for our caregivers for another cardiac arrest survivals. If I should take it to, again, 3 take-home messages: team up, respond quickly, and take care longer. Thank you for your attention, and happy to answer questions if I know how, because you know in pediatrics we sometimes have very scarce data, so hopefully I will be able to answer what you have.
Thanks, Jana. Luckily, we have now a little bit of time for answering a lot of questions. Franziska, what are the first questions for Jana? And then we can come up with questions to the other speakers.
Right. So there have been a lot of questions regarding the rescue breath. And I would like to start with a tricky one. It says, if the 5 initial breaths can't be given in time, should one start CPR right away?
Yeah, so we talk a little bit about it in the guidelines. If you don't have, for example, you are in hospital and you do not have any equipment with you and you do not want to perform mouth-to-mouth ventilations, you should rather start chest compressions, and then as soon as you have your equipment, you start with ventilations. So that's the comment. You should never delay chest compressions because you are waiting for the equipment. But of course, to start with, ventilation is the normal standard of care in children.
Right, thank you. Then another person asks, if how the rescue breath should be given. The person has well, I'll just read it, I'm sorry. So it says, I've always learned that you should stop blowing once you see the patient's chest rise to prevent from blowing air into the stomach. Now I see that in a lot of cases, the ventilations appear to be ineffective. How careful should we be to give the rescue breath?
Okay, so basically, yes, we want to avoid both hypoventilation and hyperventilation, and it is tricky to do it correctly. So you should always train yourself. That's my, you should take a course, BLS course, where you try it on pediatric mannequins. But of course, in real patients, this can be also tricky, even if you are trained. To look at the chest, it is the best tool that we have at the moment. We are testing some devices that might give us feedback, but they are not yet recommended because we do not have enough data on them. But it's, I believe, some way forward probably for the next round of guidelines. But at the moment, looking at the chest is the only thing that you should be doing. And you have to be sure that the chest is rising. Okay, it doesn't have to blow like the balloon you should want to blow to the sky, but you should see the chest normally rising. I hope that answers. We have some videos as well as a part of our guidelines, so you can check it up, and through the QR codes you can see the videos that will show how we think it can be done, but it is also, of course, on the mannequin.
May I ask, Mike, for ventilating, also in adults, there was a slightly change with the use of the mask and the ambu bag or the whatever bag you are using. Could you explain a little bit hand position to make the ventilation more effective?
So within BLS, we haven't really spoken much towards the use of bag valve mask for assisted ventilation, and the reason for that is it is even amongst healthcare professionals, it's very easy to do it wrong. We focused within the BLS guidelines on traditional mouth to mouth and mouth to nose ventilation and the use of sort of pocket shields. We don't within BLS recommend that sort of we have widespread use of bag-valve mask. There may be some circumstances where trained responders have regular training. So, for example, lifeguards, firefighters may be routinely trained to use bag-valve masks for ventilation in terms of the BLS context. But we haven't made a position statement that, for example, all first responders should be trained to use those. We recognise that we're seeing increased use of them, but there's currently insufficient evidence to support that we should recommend widespread adoption. So for now, we are sticking with the recommendations in terms of mouth-to-mouth ventilation or mouth-to-mask ventilation with sufficient ventilation to see the chest begin to move. That way we have enough to know that we're getting air into the lungs, but if we're not expanding the chest, as Jan has already mentioned, we don't want to be forcing air into the stomach because that will create a whole other world of problems for us.
There's an interesting question for Enrico, Francisca.
Right. It is the question of what type of blood should be collected, either serology or EDTA, and whom the probe should be given when you're doing it out of hospital.
So the blood is in ADTA, so a classical blood tube in ADTA, so 5 or 10 milliliters is enough to do a genetic test. I have not understood the second part of the question.
Whom should you give the probes when you're out of hospital, when you're an emergency doctor and working out of hospital because it has been an out-of-hospital cardiac arrest?
Yeah, it's a difficult answer because you have to create a system. You have to create a system with hospitals with the capability to perform such type of analysis. For example, in our region, in Lombardy region, we are starting a regional project to do this type of genetic test in all the region, and all the tests will come in my hospital, in Pavia Hospital. There are few other hospitals in Lombardy region who are able to do the test, but not all the hospitals, obviously. And so the suggestion is to create a local system, a local framework to do this type of test, because if you have this blood, but if you have no one who can analyze it, it is unuseful. But the university hospital, the third centers usually have the capability to do so. So you have to create a system. System saves lives also in this case.
Right. Thank you so much. And speaking of system saving lives, I have a question for Sebastian. I've just recently been on a German Congress, and the question there in the pediatric life support was regarding the family presence during CPR was obviously always, does the family really want to see this? So there was a great hesitance, and that was always the fear of people, like if the family really wants to be there during the resuscitation.
Yeah, well, of course, we can't force anyone to witness resuscitation, so we wouldn't like get the parents and make them stay, kind of. So if they say, well, I don't want to see this, well, yeah, then they don't see it. But we would ask them. And for example, in our system, that's been a change because in the past we didn't routinely ask. So if they came to us and said, well, we want to stay, and then we would let them in the past, but we wouldn't actively ask them. So what a takeaway from this could be now is actively ask if they want to be a part of it, not just be present, but a part of it. Like maybe if you have the resources, have someone explain what's going on. But my advice would be actively asking.
Yes, thank you. Tino, do you think we have room for one more question?
Yeah, one more is easy, and then we round it up with a final take-home message from all the speakers.
All right. So There's probably one last PLS question. There's one person asking when you should call 112 when you're alone with the baby, and I think that's an important one to clarify the new algorithm.
So now that we have a unified algorithm, you should call as soon as you find the patient, the baby is unresponsive. Yeah, so you just call first and then you start checking the breathing. So it's the same as in the BLS, the sequence is the same.
Okay, thanks, Jana. So please, we are coming to the end. I would like to ask all the speakers for a final take-home message for our audience. So Mike, what would be your take-home message for our people listening to the webinar?
So the BLSSEC is keen to stress that everybody can learn CPR and everybody can perform CPR without causing harm. So that would be our key message.
Mm-hmm. Enrico.
Sorry, but I have not understood the last 2 minutes because I have a fault of connection.
We are at the point of closing the session. What is your take-home message for the audience?
The take-home message is collect high-quality data. It is essential to have any type of epidemiology data. So try to collect high-quality data in all Europe.
And participate. And if I collect data, what I'm going to do with the data?
Yeah, and create registries. This is the key message: is collect data and create registries. Sorry, I forgot the second part. Create the data, collect data, and create registries.
Good. Sebastian, system?
Have a look at your system and try to measure and improve it.
Mm-hmm. Good. Jana, you had a very nice take-home message, but you get also the chance.
Yeah, team up, respond quickly, and take care longer of your patient even after post-discharge.
Mm-hmm. Good. Thanks. Final message for all of you from Franziska.
Right. I would like to thank you again because we've had also a lot of messages saying that you've done a great job. And then I would like to say that there is another great webinar on Wednesday, January 28th with 4 wonderful speakers. And there'll be the topics education, ethics, first aid, and newborn life support. So it will be another great session and opportunity to have a quick view on all these 4 topics and know about the changes in the new guidelines 2025. And now I would like to thank you all, thank our speakers, and thank the audience for great questions, and wish you all wonderful Christmas and festive season in the next days. And that we slip into a good new year 2026 with a lot of great evidence and good guidelines.
Bye.